He moves through a corridor so quiet it seems every footstep might echo forever. A place built as much for solemnity as for security. The walls are thick, lined with cameras that trace his every movement. Guards watch, their faces set, as he passes through layers of barriers meant to separate the world of the living from the room where a life will end by chemical means. Inside, the air is sterile, the lights bright and even, and everything is arranged with clinical precision. This is not a hospital, yet all the trappings of medicine are present. At the center of the room sits a gurney, straps waiting, ready to hold the human body still for what is to come. He lies down and the process begins. Medical gloves snap on. Alcohol pads cleanse the skin of his arms. 2 intravenous lines are placed, one in each arm. This dual setup is not redundancy for healing, but a safeguard against failure. It's a lesson learned from past errors, where a single failed vein meant drawn-out agony. These lines, called cannulas, are inserted with practiced care, threading plastic tubes into living tissue, opening a portal not for nutrients or healing fluids, but for the irreversible flow of lethal chemicals. The first chemical is prepared. Its identity varies by state, dictated by shifting protocols and the availability of drugs. In years past, it was sodium thiopental, a barbiturate so potent that in ordinary medical practice, a fraction of a gram would induce deep anesthesia in seconds. Here, the dose is multiplied many times over, enough to silence consciousness if delivered properly. The drug enters the bloodstream, traveling through veins, propelled by the beating heart. It crosses the blood-brain barrier, flooding synapses, suppressing neuron activity in the cerebral cortex and brainstem. Ideally, within seconds, all awareness ceases. The world slips away, and the subject enters a state akin to deep surgical anesthesia. But sodium thiopental is no longer widely available. In its place, many states use midazolam, a benzodiazepine used in medicine to calm, sedate, or induce sleep. Midazolam acts on GABA receptors, dampening the electrical chatter of the brain. However, it is not a true anesthetic. At even the highest doses, it may not erase all awareness or block pain. Autopsy reports and witness testimony reveal that, under midazolam, some inmates have gasped for air, twisted, or vocalized, signs that the sedative barrier is incomplete, that the mind is still awake, at least in part, as the next steps unfold. With the first drug administered, the second follows, typically pancuronium bromide or vicuronium bromide, both neuromuscular blockers. These chemicals are designed to paralyze every voluntary muscle in the body. They act at the neuromuscular junction, blocking acetylcholine receptors, so that nerve impulses can no longer cause muscle fibers to contract. The effect is total immobility. The eyelids cannot blink. The tongue cannot move. The chest cannot rise or fall. The diaphragm, the muscle that draws every breath, is stilled. Yet the brain and mind, unless truly anesthetized, are untouched by this paralysis. The heart continues to beat. The senses may still perceive. If consciousness remains, the paralyzed person is trapped inside their body, unable to signal pain, unable to cry out, unable to breathe. This paralysis hides suffering. For witnesses, the process appears calm and peaceful. The body does not convulse or thrash. There is no outward sign of distress, but inside, the biological machinery is in crisis. The lungs fill with fluid, a phenomenon known as pulmonary edema, observed in the vast majority of autopsies. The weight of the lungs doubles as fluid seeps into the air spaces, depriving the body of oxygen. The sensation, according to medical experts, is like drowning from within, gasping for air, yet unable to move or call for help. It is a suffocation masked by stillness. If the sedative has failed to truly erase awareness, the experience is one of silent, invisible agony. The mind may be fully aware as the chest tightens, the airways fill, and breath becomes impossible. Legal and medical authorities have raised grave concerns about this hidden suffering, but the process continues, largely unchanged, across much of the country. The third and final drug is potassium chloride. In medicine, potassium is a vital electrolyte, essential for muscle function, especially the heart. In high doses, it becomes a lethal poison. Injected rapidly, potassium floods the heart cells, disrupting their electrical activity. The orderly rhythm of the heartbeat falters, then stops. The heart seizes in a final, irregular contraction, unable to pump blood. Circulation ceases. Oxygen delivery halts. Brain cells die within minutes. Death, as defined by the cessation of cardiac function, arrives quickly. But the journey there may have been filled with pain. Potassium chloride is intensely painful to inject, causing a burning, searing sensation in the veins and heart. So much so that veterinary guidelines prohibit its use unless the animal is deeply anesthetized. Yet in human executions, medical certainty about unconsciousness is often lacking. This 3-drug protocol was devised not by pharmacologists, but by a medical examiner in the late 1970s, seeking a new method that would appear more humane than previous forms of execution. It spread rapidly, often without rigorous testing or oversight. The process demands perfection, accurate IV access, exact dosing, and constant monitoring. Yet, because of ethical prohibitions, physicians rarely participate. The American Medical Association and the Hippocratic Oath prohibit involvement in executions. As a result, non-medical personnel often carry out the procedure, sometimes with tragic results. In recent years, some states have experimented with single-drug protocols, using massive doses of sodium thiopental or pentobarbital. These protocols aim to simplify the process and reduce suffering, causing rapid unconsciousness, respiratory arrest, and circulatory collapse. However, drug shortages and manufacturing bans have made even these alternatives rare. The reality is far from the sterile calm that is projected. Each step, sedation, paralysis, suffocation, cardiac arrest, can either mask pain or inflict it, depending on the effectiveness of the drugs and the state of the mind. The process is irreversible. There are no second chances, no corrections, only the finality of death and the questions left behind. Lethal injection was designed to look peaceful, but beneath the surface, biology tells a story of complexity, uncertainty, and sometimes hidden torment. In seeking a humane method, society has constructed a procedure more about appearance than certainty. The truth, revealed on the microscopic level and in the lived experiences of those subjected to it, is often far messier than the silent stillness seen from the corridor outside. Through understanding the process, from IV setup to the last heartbeat, we are confronted not just with the science, but with the profound ethical and human questions that surround the end of life by lethal injection. Knowledge, unflinching and honest, remains our best tool for facing these hidden realities.